Warning: this podcast does not introduce any new information outside the Foundation's curriculum. Listener discretion is advised.
Hey there, friends and curious minds tuning in. Welcome to another episode of Real Doctors, Real Friends, the podcast that takes you on a behind-the-scenes tour of the world of medicine, one episode at a time. My name is Dr. Roshan Abraham, and I'm a family physician and faculty here at the University of Alberta. Joining me is my co-host, Dr. Shereen Hamza. Shereen, how are you doing today?
Hey, Roshan, it's going great, especially because we've got an incredible guest today. We're diving into a discussion of the primary care crisis, and who better to guide us through it than Dr. Dave Pickle, the Longitudinal Clinical Experience Coordinator at the University of Alberta. Dr. Pickle, welcome to the show. To start off, can you share with us a little bit about your background and what led you to this role?
Yeah, thanks for having me here. You know what? I kind of fell into medicine and primary care. I just was a microbiologist, or I thought I was an aspiring microbiologist.
I did not know.
And I couldn't get any results, so I thought I'd write the MCAT and see what happened. And so I was pretty undifferentiated when I got into medical school. I quickly learned that I wanted to be a generalist. And then I was pretty set on a general internal medicine for some time. I had everything kind of teed up in CARMs. And then I pulled the plug on it, and I said, no, family medicine is what I want. Just going through all my experiences in medical school, a couple of preceptors in particular really had an impression on me. And, I was trying to fight what I think was my natural inclination. Just because in medical school, you get so caught up in the academic world. Certainly in my day, you get taught by specialists.
Right.
And it just seems, I just felt that there's an expectation to do something in a hospital. But I went with primary care, family medicine, and I love it.
Was there a particular defining moment that made you think primary care is the path for me?
I think, interestingly, LCE for me, we didn't have LCE then. It was, I think, called CBE.
Yeah.
And my CBE experience was pretty poor. I thought family medicine, like I think there's a lot who think it is. It was just coughs, colds, and ear flushes. It was pretty uninspired by that experience. But in my third year, I got connected with Gordon Chaters, who was a family doc at the Alex. And he was just so comfortable in his own skin. He was just very relaxed. His patients loved him.
Yeah.
It was very evident. He loved his patients. He knew everybody. He could tell me about extended family and the last 10 years for every patient he saw.
Wow.
And if there was a defining moment, I think that's what that would be it, or certainly that started the ball rolling in that direction for me.
Okay. And when we're talking about sort of those defining moments, I think we sometimes have to look back on those when we're struggling, as many family doctors are right now, struggling, and we're talking about a primary care crisis. It's a term that gets thrown around a lot, but what does it really look like on the ground? As dramatic as it sounds, are we being overly dramatic? I don't think we are, but I'd love to hear from you and maybe hear a little bit about your practice, because your practice differs a little bit from mine.
Sure.
Yep.
I think it is a crisis. Certainly things get framed politically, and I think they have to be framed that way for action to happen and for people to become less apathetic about it, and certainly to initiate change from our leaders. But I can't speak. I speak to patients every day about what it's like in the emergency department in acute care, and that is scary. I've got patients who are coming to see me a week after they went to emergency for 9 hours and left.
Oh, wow.
And for whatever reason. And that's happening often. And then patients who do stick it out in emergency, they just tell me about the horror show in the waiting room, how hard the staff, triage, docs are working, and people just keep coming. There's no place to put anybody.
Yeah.
So, I hear about that, just like we all do from friends and family and colleagues and things. And I see it in the kind of the downstream effects on my patients, like clinically. But I'm not in acute care, so I mean, I don't see it firsthand. Same thing with rural. I think obviously it's a huge, I think it is crisis for sure, rurally, because hospitals are shutting down, emergencies are shutting down, and it's been like that for quite some time. But just with the pressure on the entire system, it's become that much more acute in rural areas.
Yeah.
So from my from my perspective, aside from the acute care, rural care, it's just nobody can find a doctor. I think the president of the AMA, the number he used was 800,000. I don't know where things are at now. That was some time ago in some communications that he sent out publicly. But that's just a ton of people looking for a family doctor. I used to get asked once in a while by a patient, you used to be my doctor 10 years ago and I moved, and can you take me back? Or my sister's looking for somebody, or I've got a friend. Now I get asked, and I'm no exaggeration, 4 or 5 times every single day.
Yeah.
Wow.
And these aren't just and these are patients mine asking about relatives, their wife, I get asked by neighbors.
Yeah.
We get people just cold calling our clinic, walking into our clinic looking for a doctor. They're desperate. And I get people coming up to me every day saying, I'm just so happy, feel so lucky that I have a doctor. And nothing, I think we have a relationship and that's what you want. I'm happy that we have that kind of that medical home, we have that relationship. But they're just happy they have a doctor.
Yeah.
Because if you don't, you're rolling the dice, really. And you're relying on acute care, you're relying on walk-in medicine. It's just, it's tough. And, people are getting older, people are getting sicker.
Yeah.
And it's just going to get worse.
It's interesting you should mention that. I never reflected on that, even though I have. So we have different practices. I mean, we both do general family medicine. I mean, we try and I think do as general of a scope as possible, but you have more of what we call a fee-for-service model that sort of that you're under, and then I'm under the academic model. I mean, it depends on when people are listening to this in our series, but we do go over sort of the different models with Paul Parks. Dr. Paul Parks was is actually a guest on this season, and he does go into a bit of detail. But if someone's dropping in, right, like fee for service is kind of how it sounds, right? Like basically any time a patient sees a family doctor, any doctor really for that matter, in the province of Alberta and most provinces, then a code is designated, usually with some sort of diagnosis, and that's matched with a fee code in which that's then sent to the provincial government or an organization, and then you get a fee for that. And you bill accordingly based on who you see throughout the day, and that's what you make.
Yeah. So you get paid for everything you do.
Yeah.
Or everything you say you do.
Everything you say you do.
Yeah.
So it is like when working perfectly, I think it can be a good system, and I think I get remunerated adequately. Like I feel valued by my income. But as for doctors at large in Alberta, first and foremost, it can be abused. And it incentivizes the wrong things. It incentivizes volume, and so what's difficult, and like my practice, I've got 1,400 patients. I've got my average age is over 60.
Yeah.
It's getting older, and as patients get older and more complex, it takes, there's a lot of follow-up that needs to happen. There's a lot of complex care, and that doesn't get paid the same way as somebody coming in for a birth control refill. I mean, there's time modifiers which help for sure. Like I get paid for if I spend half an hour on a chart, I get compensated for that. But if something requires follow-up the next day, I don't. So there's the fee-for-service system is, I think it works well when it works, but it's got a lot of deficiencies, and the right things aren't being incentivized.
That's so well put. And being in a academic center where we are salaried, so we do something called shadow billing, where we send those codes out to basically justify our ongoing funding.
Yeah.
But at least then we have a little bit more flexibility with the time. It's interesting. So I'm at 0.5, and usually 1250 is what we designate as full-time family medicine. So I'm sitting about a 620 or 630 as like a 0.5. And it's interesting that you should mention that. So even though you're not necessarily compensated for it, the struggle is still there for me when you feel really the system sort of on your shoulders, whether it's that follow-up the next day that isn't really getting looked at in the same way as like a visit, right? Where there's this background talk with us and the nurses and the patient to sort of coordinate care, right? To see, and sometimes is even more important than the visit, right? And there's so much that we do in primary care, as do a lot of our specialist colleagues as well. But there's so much that's left unsaid and that therefore isn't actually compensated, or it's not documented and therefore not compensated. So I do think that, like, I feel that even though I'm in an academic center and we're salaried and it's sort of like this flat rate no matter what, I feel that, but I can't imagine what so many people are going through in our fee-for-service world at this moment with rising costs, inflation, overhead going up, and billing codes staying the same.
Yeah, that's certainly another issue is the cost of running a practice has gone up significantly, and the fee codes haven't been in step. And so, like, I did academic medicine as well before for a few years, and when I switched over to fee for service, and the reality is, you see, like, there's a degree of altruism in medicine across the board, but when I was working not in fee for service, it felt more altruistic.
That's what my wife says.
So now I can't but help if I got a very difficult encounter. Or a long encounter, I can't but help thinking, okay, well, I'm going to get paid this for this. You know, this is how I justify it. And then and we're talking again in general where people are trying to keep practices open with the rising costs, and then you start, and all the paperwork and admin work that you don't get paid for because you don't get compensated for it. It also just that frustration, that resentment. That satisfaction in what you're doing goes down.
Yes.
And that contributes to burnout. So I think it can be reframed. Like, you can say, okay, well, I got paid for this yesterday, or this is part of what I signed up for, which is fair. But you end up, when costs are going up and things, you're getting asked to do more. And same on the academic side too, you'd be asking if you to do more and more for the same amount of time that you have. It becomes just more of a slog, and it just wears on you, especially when you're dealing with heavy stuff. And every day there's something heavy. There's something happy, but there's always something heavy. So
I'm wondering about documentation. So we talked about sort of the weight of documentation and admin work, and part of it, it's funny, when I was doing medical school and I heard about the woes of paperwork. I think it's important to contextualize what that paperwork actually is for a family doc, right? So it's not all just forms. A lot of the paperwork is the communication that we do with our staff. So through the electronic medical record, which has exponentially increased as we shifted from paper to electronic delivery. And then actually the clinical documentation that's relevant for the actual clinical encounter, as well as then sort of jotting down notes around labs, and all these things add up. That is what makes up our paperwork. So the things that in a hospital where they jot things down, they make quick notes on it, right? We have to do that as well, but we don't have a full team behind us.
I see. I was going to ask, how does this compare to specialty?
Because in specialists, especially if you're in the hospital, right, you've got a team a lot of times, and usually other learners, and especially medical learners, like residents and medical students, who are doing that documentation for
Okay.
you, right?
Yeah.
But you're still taking that fee code home.
Interesting.
The residents are getting paid separately
Yeah.
through the provincial authority and partly through the university, or I mean, it's through the provincial authority like AHS here. But we don't have that in primary care. I mean, that's not true. The small number of academic clinics and physicians, we have residents and medical students who do that documentation, but compared to the volume that you see in other specialties.
And volume is not like in the hospital, you're going to round on a patient every day. You're going to document on a patient every day. And you're going to bill for that every day. So today's work is today's work. Tomorrow's work is tomorrow's work.
Yeah.
In primary care and a fee-for-service environment, you spend like my day today. I mean, I saw, X number of patients. To get through a day, seeing all the patients I need to see and finishing notes, that is all my time, including lunch. Like that is all my time and then some. I'll have a few challenging notes to kind of touch up later. Yeah. And that's after I'm practicing for 15 years.
This is it. I was just going to say,
like when I started, I would be like, I would try, you're just so focused on trying to figure out what's going on and you're clunky with your notes. So like I would be doing charting for hours in the evening just to catch up. That's just to catch up to neutral. Then you've got everything that you did and ordered the day before, the week before, and the month before.
Oh, okay.
So I've got in my task box 50, 70 tasks that come in that I have to deal with somehow in between. Yeah. And so that ends up happening in the evening or when you have a chance. And there's no time because you're dealing with the patients and today's work and today's notes. So you're going to get paid for, in the fee-for-service model, you get paid for the work you do on that day. The next day, all the labs come in that you're dealing with, the specialist reports that you're dealing with. You don't get paid for that unless you initiate a patient encounter and then that starts more documentation. Yeah. Right? So like, everything you do is you feel like you're just kind of getting buried a little bit more each day. And then you spend your weekend catching up, and then Monday all of a sudden you're 10 feet underwater again. And then if you got one challenging patient, somebody who's palliative, or somebody with dementia, who's got some issues with driving or their home situation, that could take up hours, and then that's everything else gets put off.
We're really selling family medicine here.
So but we're
I'm glad we're having this discussion. I am really glad.
We're emphasizing the challenges.
Yes.
Yeah.
And I am really glad because I've listened to so many podcasts and medical education podcasts, medical podcasts. I hear about on the news, paperwork. What does that paperwork actually mean, right? And I didn't even conceptualize it until not even in residency. I don't think you get a full grasp of it until you are met with that task box, that inbox, where there are so many different people's lives that are like filtering through that task box. That's what it is, right? And you have to make decisions about their lives in short order. And as you get better at it, you make faster decisions, right? As your processing becomes faster. But when you start off, it is a slog. And it's a slog for some people, no matter how long they've been in it, because of the patient panel that they decide to have and the lack of support that they have from like a multidisciplinary team. Yeah. So we were just talking about clinical documentation. We have an assignment for the first year students around reflecting on a SOAP note. So they create SOAP notes in groups. But it's around one of the stories of the week that we present every week or most of the weeks, and then they actually write a reflection. It's mostly to help them analyze the CanMEDS framework, but it is informally a way to get some formative feedback around SOAP notes. Yeah. And it was just, there's a lot of questions about how patients can access those notes, and we had a lot of questions about sort of what you would put in a note, what you don't put in a note. But I just thought it's something that came to mind for me today because we just came back from the lecture about how much of that paperwork actually takes up our life and what it actually means. Yeah. Yeah.
And I guess I got a little bit focused on the workflow.
That's good.
And how the documentation today affects your work tomorrow. But going back to the actual note itself, and I've gotten better at this. 14 unfortunately.
Me too.
But you want to write your note to make your job easier the next time you see the patient.
That's exactly it.
And so you can't write everything. You don't have to write anything. You shouldn't write everything. You get better at distilling down what's pertinent. I try not to filter myself too much, like based on what the patient might read. I want to be as accurate as possible.
Yep.
And then I've had one patient ever ask to look at maybe two.
I bet too.
Yeah, maybe to look at all my notes. And if there's something that they're not going to like, that's fine. It's justified because I wrote what was accurate at that time. There's a few times you have to be a little bit careful with insurance. If you're talking hypothetically about something, I've got a ton of patients. They're older, so they're snowbirds. They go down to Arizona for the winters. And insurance is a really, really big deal, like a really big deal for these patients because it's expensive and this is their life.
Yeah.
So if you change your medication within 6 months, their insurance doubles or triples. In some cases, they can't go.
Oh, wow.
And that's something that just if you stop a medication, if you stop, their blood pressure's good, you're like, okay, I'll take you off your amlodipine.
Oh my God.
Yeah.
That affects their insurance, right? So
okay.
you have to be cognizant of that. So I get all my snowbirds to come in when they get back, and we do our medication review right when they're back.
Yeah.
And we have a plan, and we document that plan, and then they were going to be stable as far as insurance. So there's things you have to with your notes. You learn these things as you go, but I wouldn't censor yourself too much because you want to be first and foremost accurate.
I agree
and
with
forthcoming.
that. Man, surprising we haven't talked more about this before, you and me, but like I do think about the medical legal. I don't think about if this was ever in a court of law, because that to me feels extreme. But I do think about the insurance paperwork, right? Sometimes that comes in like if this is going to show up and if this is going to go through some insurance paperwork, am I being as good of an advocate as I can be for the patient and making sure that I don't maybe say something that could be potentially used against them. But the truth of the matter is there's so much that goes into that soap note for us as family doctors. And I do love what you say about making it easier for the next person. And the next person just doesn't have to be you. Yeah. It can be one of your colleagues too.
Yeah, you have to, especially now with, now our chart's going to talk to each other in the future.
Yeah.
So it could be, it may be somebody in a hospital.
Exactly.
That's not happening
right now.
But it will. So yeah, you want, and I've got if I go away on vacation, I want my patient to be well taken care of. So you want to be as accurate as possible for that person coming in. And and accurate means nuance. That is like, I try to put something personal in my notes as well, so that you can get, again, I keep talking about it, the patient's sort of experience. It's not just, you're not just talking about their blood pressure, you're talking about their diabetes is a better example. You're talking about their diabetes in the context of their life.
Yeah.
And so it does, you don't have to write, like I said, a novel. You just have to write you have to write what you talk to the patient about, what you get from the patient. And I don't want to, I'm just thinking back to what I said about insurance. I don't want people to get too, or students to get too like uptight about writing notes. The bottom line, what I want to get across when I'm writing a note is just be honest, don't worry too much about it. But when you get to know your patients, and that's, your number one job is to actually to get to know your patients and where they're coming from. Like the insurance stuff, for example, and the fact they're snowbirds and they're worried about it, they're filling out their insurance paperwork accurately. That comes out when you actually talk to your patient. Get to know that comes out. So you just get to know your patients, be honest and accurate on your notes.
Yeah. So do you find your notes help in building relationships with your patients in the long term?
Absolutely.
We talked about that today in class. Because I think that was new for a lot of people. They're like, oh, this is just clinical documentation. It helps to build relationships.
Oh yeah, it's like like I said, there's nuance. I think it's good because it colors the visit in a certain way if you write something more personal, but also patients love it, right? And I don't mean like, oh, they just eat it up, but they feel valued. They feel like you care, even though you, of course, you do. But it just it moves it to a different, a different level.
Yeah, that you've heard them.
Yeah, you've heard them. My parents go to see their family doc, and they'll report to me the experience. And it's like, I had to say everything all over again. It's like he never listened. I'm like, well, Mom, he saw you like a year ago.
Yeah.
I mean, and he's seen like 30 people every day since. Like, how is he supposed to remember? But that's what she takes away. She feels like it's personal.
Yeah.
So, and just to follow up on that, just to kind of talk about primary care, and what I love about it is when you develop these relationships with these patients and with all these sort of like this kind of it starts in documentation and getting to know your patients. Like they trust you more than they'll see their specialist, and they'll come talk to you and they'll say, well, this is what the specialist said, but I want to know if you agree.
Yes.
Or this is a specialist said, but you are, their primary point of contact, but you're also the person they trust the most by far.
They value your opinion. Yeah.
You're kind of like family.
Yes. Very nice.
Although some patients with extremely rare disorders or complex disorders end up seeing specialists, especially here in Edmonton, where we have a lot of specialists who take on that role, not primary care role, but I would say primary provider almost, like not the primary care provider, but the primary provider. A lot of the genetics patients, right? Like they'll see those patients, they'll trust those specialists heavily as well. Yep. And pediatrics is another anomaly here, right? Because no other major center, to my knowledge, in Canada has general pediatricians actually follow kids for primary care other than Edmonton.
That surprised me, actually.
Yeah. Which, I mean, I grew up in Ontario and I saw a pediatrician, so I'm assuming things have changed. But for the most part, we are one of the few places where pediatrics actually sees. And pediatrics we haven't even touched pediatrics yet, about sort of, because they are primary care providers too for their kids. Yeah.
And going back to primary care and specialists, I find that my specialists who were seeing my patients sort of more on an ongoing basis, like you got your gynecologists who are doing kind of routine PAPs and mammograms and wellness checks for some of my female patients, pediatricians, even some your rheumatologists. I find I'm getting a lot punted back to me, which I think is good in some ways, but I find that more and more is being deferred, and that just adds to just see your family doc. Oh, your family doc will deal with this, and because they're overwhelmed as well. So again, that is putting more strain on our primary base.
And just to put in this as well, generalist training doesn't happen as much anymore. Yeah. So our rotating internship, which was phased out in the 90s, means that all of our specialists, and when you think about the CanMeds framework, is very much specialist focused. It stands to reason, right, that we're going to have more specialist-based approaches to training, and therefore the way that you work is going to be more specialist based. So anytime you do see something that might be outside of your scope and that's more generalist, we don't have those specialists anymore that'll say, oh, I'll just do that, right? Which is what they used to do.
Yeah, absolutely.
And like I won't talk. Yeah, there are definitely some repeat offenders these days about sending it back to family docs, but we definitely won't get in there. Before we get to one of our friendship questions, I did have a question about AI and technology. Because, in the academic world, it has to filter through all our different sort of department levels and get approvals. What is it looking like? Because we think about the documentation and the paperwork that we have to go through, and we think about the potential that AI actually has to maybe solve this, although it is a double-edged sword. What have you seen in the fee-for-service world? Have you had a lot of people come up to you, like reps come up to you and say, hey, this is a product that I think is going to work for you?
Believe it or not, I haven't. Reps.
Yeah.
But I'm like... newer grads and residents now are talking, like just trumpeting their AI note takers. And our EMR, the EMR that we use, it's a smaller company out of Calgary, and they're pretty responsive. They've got an AI plug-in, or I don't know.
Yeah.
I'm an old dog. I just...
bot. Maybe we'll call it a bot.
Yeah. They've got something on there that is kind of being trialed, and, there's a few clinics that kind of tried it out, and it's pretty rough. But it's being pretty rough, it's still pretty impressive. You just turn it on during the visit and have your normal visit, and it just spits out your note for you. And then you can edit it and that and other thing. So that was through our EMR. I saw a few sample cases, and then my resident had another system. And he showed it to me, and it was impressive. Yeah. So I think, yes, it certainly could make workflow easier. But you just wonder, like, if if we were relying, I mean, obviously we've got our training, and we're going to put things into context. We're actually facing the patient and talk to them. But
Yeah.
the more we rely on this stuff, the less we're going to be able to use our clinical skills, right? So like, I do worry a little bit. I think maybe it's just the dinosaur in me, but I worry that we're going to lose skills and lose how to like, and documentation. Like if we got somebody documenting for us, I can't write. I can't, like I write 3 sentences and my hand cramps up into a claw and my arm gets sore. Like I can't write cursive. Like if we're having somebody document for us, we'll be able to craft a note, a soap note.
So I am. I mean, I don't think you're a dinosaur. First of all, not just because you're a great guy, but you're not a dinosaur. For someone like me who actually embraces tech, like more so than the average physician and medical educator, I am concerned about AI, and it's for 2 reasons. One, what sort of back end sort of safety protocols do we have? Because if there's any generative process in there that is sucking in that information and spitting something out, where is that information going? Right? So yes, safeguards are going to be in place, and you would think it's a closed system, that all this patient information is held and data is held within a closed system. But with the way things are going and the way that I'm sure it can be marketed or advertised, is that, oh, you'll get a better response if you put it out to this bigger system that, you know, that draws from all these different databases and programs. And so that's one area that I'm just going to assume people know. The big one is clinical skills. So I completely agree with that. When I review a resident's note, it's different than when I review my own note and when I write my own note. And it's just because, oh, it's there, they did a good job, you know, I quickly look through it, make sure there aren't any things. But when I look over my note and I actually have to go through the process, it's like that system 1, system 2 thinking. One is like more deliberate and analytical, the system 2 thinking. And system 1, you're just sort of like, okay, I trust this resident, you know, a few words here, everything. I mean, I'm supposed to look over everyone's notes properly, but
No, I'm the same way, yeah.
But that's what I worry about with AI, right? So if every single visit is like that, will we miss certain things in the documentation? And then the bigger thing is that learning. The learning that I've gathered over the years of actually documenting my own clinical encounter and the analytical work that I have to do means I'll be like, okay, I'm now going to look this up, right? I'm going to look into this a little bit more. I'm going to do, when I'm going through that, I have to be more deliberate about it when I'm reviewing somebody else's note or if AI were to do it. And I think that then is on us as medical educators to enforce that in the training when we are forced to look at AI, because it comes on my desk like once a month, AI. And we do have to be very, very diligent in ensuring that students maintain some sort of clinical acumen and clinical skill development. Clinical reasoning development
Exactly.
needs to still happen, even if somebody else or something else is actually spitting that out for you.
A couple of quick follow-ups to that. So in an academic setting or as a resident or a new grad, sure. But when you get, we're talking about all the pressures of seeing patients, how easy would it? The first thing that's going to go is your clinical reasoning. You're just going to look at what's spit out and then interpret it. You're interpreting not necessarily the patient's story, but some other interpretation of it. It's like telephone. So so that concerns me. And then also that was what you said about how it's formative writing the note and that type of learning. I remember when I used to run narrative reflective practice. We were talking about that before we went online here. And I used to tell students that, as far as, and this was all about understanding the patient's illness experience and getting away from kind of the granular details. But writing the patient's story and then reading it, there's different levels of reflection. So listening, writing it, and reading it, that's what you're going to learn, you know, and you lose all of that, you know? And I tell residents now, it's like, okay, well, your note, having a good note is going to help you come up with the answer.
Yes.
Because it makes you organize your thoughts. And if you don't have a good note, they're all over the place. So when LCE students start, it's spaghetti that gets thrown at the wall. And that's good because you just want to get information. You want to talk to the patient and understand where they're coming from. But as you get farther and farther along, it gets more and more organized. It gets more and more distilled. There's the pertinent positives, the pertinent negatives in a cohesive plan. And that's how you come up with with your diagnosis and management plan. It's
Yeah.
by going through that process. And if it's being done for you, then
Yeah.
Yeah.
Fantastic. Well, this has been a great discussion.
Well, before we wrap up, we have a traditional friendship question. If you could eat only one food item, so one food item for the rest of your life, what would it be? And we have to keep in mind that we have to try to get all the nutrients we need from this one food, or else you might have consequences to health later down the line. So is there anything that comes to mind for
can I
one
blend
favorite
things
food?
together?
I'm all about combining. My answers are usually composites
Yeah.
of things. So yeah, you can blend.
How much are you going to blend, though? Because then we're kind of moving away from...
Well, can we say one meal? Does it have to be like one item?
Well, I mean, I'll say this. I mean, this
I
is
like
kind,
oatmeal.
this is kind of embarrassing, but I'm kind of oddly proud of it. Right after residency, actually, when I started practice, I was unattached for about 10 years, and I ate the same meal for lunch and dinner every day.
What?
Oh, it must be good.
It was delicious. I looked forward to it.
Yeah?
I often couldn't wait till lunchtime. I'd be eating at my desk at 11, and then I'd go home and have the same thing, but I'd heat it up.
What is
I need
it?
I need to know what it is now.
It is a wrap. I just had a whole wheat wrap. I had chicken sausage, just a little bit more flavor there.
Mhm.
Avocado, arugula,
Mhm.
that
Kind of a
Renee's poppy seed creamy dressing.
Yeah.
Just a little bit. Hot sauce, of course. And then I'd mix it up. I'd put tomatoes in it sometimes. I'd put mangoes in it sometimes. I'd put strawberries
Oh.
in it sometimes. And I'd wrap it in tin foil. And then by lunchtime, this is disgusting. I'm still alive, so it's okay. And my undergrad was microbiology. But by lunchtime, it would be warm enough to eat because it'd be sitting on my desk. And I'd unwrap the tin foil, and it's just joy, pure joy. And
Do you like it now? That's the thing.
Yes, I do. I recently, now my wife is an amazing cook, so I eat very well and have leftovers often.
Mm-hmm.
Maybe 2 months ago, I went through 2 weeks of making wraps and it was delicious. But
Yeah.
the problem is when you've got other stuff in the fridge, you need a whole shelf for all the parts of this.
Right. Yeah. All the ingredients.
Yeah. And grocery shopping was super easy, right? Same thing. There's a checklist. And I didn't, and then, I'd go out for wings or whatever, it'd be fine because I just have a wrap.
Yeah.
Wow, I think he wins.
Yeah.
Like,
that actually sounds really good.
Well, I just like it. I think it answers this question so well. What about you, Shereen?
Probably I would pick like a kebab
Yeah.
and pita bread
Oh,
because the kebab, you can put vegetables on it. You could put fruits
it's true.
along with the meat.
Mhm.
And you got to have it with pita bread. So
You can mix up the
That's-
the sauces that you can
yeah,
or whatever.
yeah, exactly. So I think that would be a good meal that has some versatilities if it was for the rest of my life,
It's kind of like an exotic wrap, is it not?
Yeah,
Yeah.
actually, yeah,
Yeah.
because a lot of people will just put that kebab right on the pita bread and pull it off, and it is essentially a wrap at that point. So yeah,
Yeah, great minds.
How about you,
I'm going to
Roshan?
be very unserious right now and do a callback to I think,
Cereal?
our last episode, Costco rotisserie chicken. And now we're going to go.
It's a good choice too.
that is a good choice. I mean, there's a lot of people that say like it's so tasty that you can't even resist eating a little bit on the way home.
Oh
I
yeah.
have heard that.
Oh, fresh and moist, yeah.
I
Like sweaty, like Vegas sweating.
drop the M word.
Yeah.
I actually use it as like part of my lunch routine. Like I chicken and broccoli or rice or something of that nature for lunch. And I've stopped using. I just use Costco rotisserie chicken.
Yeah.
And
It's hard to reproduce. Like
No,
if
it
you're
is.
gonna make a roast chicken at home, it's good, but it's different. It's not as good as a Costco chicken.
yeah.
Agreed.
Yeah. Okay. Awesome.
So is that a wrap?
That's a wrap. Oh, I love that. That's a wrap.
This might be
This-
our best episode yet.
This has been a really enlightening discussion. Thank you very much, Dr. Pickle. It was wonderful to have you here. We hope our listeners found it insightful and are inspired to engage with these critical issues
And to all our listeners out there, remember to stay tuned for future episodes. We'll continue exploring the many facets of healthcare and medical education. If you have any questions, topics you'd like us to cover, don't hesitate to reach out.
Until next time, stay curious, stay compassionate, and keep learning. Take care, everyone.